Okay, thanks, Paul. Yes, addiction and opioid addiction and cancer pain. The background of this, of course, is, I don't know if you talked about this morning, but the worldwide epidemic of opioids, especially in the United States, where it's now perceived as a serious problem. At the World Pain meeting I went to last year, this was all the talk about the opioid epidemic, and you just have to look at the prescribing practices in Australia to see the huge increase in opioid use. These are quite old data now, but you can see the use of oxycodone and fentanyl plummeting. I see there's even on Radio National at the moment a whole series about the dangers of fentanyl and the abuse behind fentanyl. Just a different way of showing that, and this is the most recent data I could find, which was still quite old, showing how no one's using morphine anymore, but a huge increase in the use of oxycodone. And this has been reflected in complications, and that people aren't being admitted to hospital with heroin overdoses anymore, heroin in the green. They're being admitted to hospital because of oxycodone opioids, and a lot more. You can see the oxycodone hospital admissions are increasing and the heroines are decreasing, because who needs heroin anymore? And a large number of deaths. These are data from the United States, but an enormous number of deaths attributed to opioids. And these aren't deaths from on-the-street heroin users. These are deaths from prescription opioids. And you just have to think about the people you know, you hear of: Amy Winehouse, Michael Jackson, Heath Ledger, Prince. All died, didn't they, with OxyContin in their blood, and they're the high-profile ones that we hear about. So this is the background. It's important to note, however, when we're talking about cancer, that the yellow and the green is the use of opioids in cancer, and by far the majority use of opioids is in the non-cancer population, and the sales of OxyContin in this country, for instance, are 95% non-cancer pain and 5% cancer pain. So that's where the problem is. And so is there a problem in cancer and in palliative care? Particularly, should we be worried about this? Certainly, if you read our standard texts, for instance, the Oxford text, they all talk that opioid addiction isn't a problem in patients with pain. And certainly, I've spent much of my practice reassuring patients that when I start them on an opioid, that they won't become addicted, because if they're using the opioid for a pain and not for a psychological reason, addiction isn't a problem. Then that's certainly, I think, the public perception. And if you look at various online resources like these, they talk about the myth of addiction in palliative care, and lots of talk over the years about this fear of addiction as a major barrier to cancer patient getting proper relief. And there have been a few studies done. This is a huge study done from Boston. All these patients had received at least one opioid during a hospital admission, and on follow-up they found that the incidence of true addiction was very low. And this is a review of all the opioid addiction studies that have been done. Now, most of these were chronic pain patients, and it's really, I find it quite hard to believe a lot of these figures, that the last one was the only one who really showed a problem, but in that one they included drugs and tobacco and alcohol as well. So how meaningful is that? Valentine is she's been very vocal about this worldwide opioid epidemic, and so I presume it's the same Valentine's made these statements. Patients suffering unrelenting pain seek opioids or opioid dose escalation, but they are not addicted. Patients who become opioid tolerant may suffer a re-emergence of pain or symptoms and seek more opioids, but they are not addicted. patients who enter opioid pain treatment with a substance abuse order may display addictive behaviour, but it's not the pain treatment that made them addicted. So a lot of information out there suggesting that opioid addiction may happen everywhere else, but it doesn't happen in palliative care. But over the years, talking to Melanie before, as I get older, I prescribe less and less, and maybe I'm becoming bitter and twisted, but I wonder if we're putting our head in the sand a bit here. I certainly, and I'm sure everybody here, has patients who come to clinic who have no obvious cause of pain but are on high dose of opioids and asking for more. Patients who come into the clinic and the first thing they ask for is their opioid script. And the whole purpose of the appointment seems to be getting the opioid script, and that's what's foremost in their mind. Patients who frequently lose or mislaid scripts. My favourite one is the dog that ate the Ordine. The dog seemed to be fine, and the glass, I don't know. Anyway, we have frequent requests for repeat scripts, telephone calls, maybe 2 weeks after clinic asking for another one. And this rather aggressive behaviour, and you often see this from relatives rather than the patients. The little old lady with genuine cancer and genuine pain who comes to clinic with a scary son, and you give them a prescription for OxyContin 80, and you just got this uncomfortable feeling as you're not absolutely sure where that OxyContin is going. I'm sure all of you have got the same sort of patients, and it's very difficult to manage these patients. And one of the problems is what is this all about? Is this addiction, or what is it? And there are a number of different diagnostic criteria and terms that are used in the literature, and no clear picture to describe the clinical problem in pain. The term addiction has been dropped by the WHO and replaced with dependence, and I think the most preferable term is this term opioid misuse, which describes a whole range of problematic opioid use. And in the literature, more and more people seem to be using this term, because I think there is this transition, this wide remit of opioid problem, and that can go from misuse, which include things like diversion, to problematic use, to dependence, and to true addiction. And there are various definitions of all these terms in the literature. Problematic opioid use is described as this overwhelming focus of opioids when patients come to clinic, a disproportionate amount of time being spent around the opioid script rather than trying to look at the pain and come up with solutions to the pain. This pattern of lost scripts, early refills, telephone calls out of hours, telephone calls to different people. This dog has ate my morphine, and supplemental opioids obtained from lots of different sources. And that's further along the spectrum, that's the word I was looking for, this transition into substance dependence, where you get classic withdrawal when it's stopped, larger amounts taken than is needed or intended, lots of unsuccessful attempts to decrease intake, and then you start to get into this whole social, family, occupational disruptions because of the opioid. And that leads into the true addiction, where you get this overwhelming desire, which affects greatly on the person's social functioning. Okay, so what should we be doing? Who routinely, when you get a new patient in clinic, takes an opioid addiction risk assessment? Does anyone here? Mm?
You're still American.
Yeah, in America they say it's absolutely essential. I asked the same question to a group of palliative care doctors, and some of them said a lot of it should be a routine, things that you routine ask patients when you first admit a patient. As registrars, medical registrars, you're admitting patient, you're admit to ask always routinely about alcohol and the use of illegal drugs. But do you ask them about psychological disease? Do you ask them about sexual abuse or pre-adolescent sexual abuse? I would suggest that very few people routinely ask this, but in America it's meant to be a routine part of the... few people put their hands up there, yes?
We have drug and alcohol physicians accompanied with some of our acute pain rounds. They're a crucial part of the chronic non-cancer pain clinic. It's becoming a necessary part of all groups who prescribe opioids.
Yeah, I would suggest that you're very lucky, and that I can't name, I think there's a dependence clinic in Brisbane, but there is one, but that's very few and far between. And so, yeah. So there you go. I think this is a controversial area. And what would you do if you found someone who ticked yes, they've come along with breast cancer, with widespread bone disease and bone metastases? They score high on this risk. What are you going to do? Are you going to deny them opioids? I don't think many people are going to do that. The suggestion is here that this is sort of a compromise, that if you do this tool and you get someone who's at high risk, you consider what they do here. You very much involve the family, because it's often the families who are right in the centre of this. You talk about the elephant in the room and discuss the problem and discuss the issue openly, so you can use all this information in formulating your treatment plan, and that ones at very high risk should be sent to your addiction specialists and dealt with in that way.
I think this is an area where electronic medical record can be used, eventually when we get more fine-tuning, but so that the story follows the patient rather than having to rediscover it every time.
And there's the drug and dependence unit, but I know the problem with the drug, which record all opioid scripts, but they're always about 3 months behind, which is a difficult. It's often very useful. Occasionally I've rung up about certain patients and they've said, oh yes, because it's usually the way, 5 years ago there were multiple scripts for morphine and et cetera, et cetera.
If we had an electronic script that went to the person that was dispensing it, they wouldn't be able to lose it. The dog would need their script, and it does block off one.
Yeah. Oh, the dog doesn't eat the script, the dog eats the morphine.
Yeah.
Yes. Yeah, and survive to tell the tale. Okay, so how is the best way to manage these patients? I think it's naive of us to think that maybe only in a small proportion, but certainly in a proportion, opioid misuse is going to be a problem. This thorough examination and pain history is very important. It's very important to do the right investigations. To my shame, I had a young lady, and I'm sure she did have an opioid misuse problem. Lots and lots of opioids were prescribed. She had a malignancy and no obvious source of metastatic disease. After a number of months, she's admitted to the emergency room. They ring me up and I sigh and say, oh yes, Mrs. X, this is the pattern. And of course she had a scan, she's got cancer from here and here, and you feel a total mug. So it's really, or more than that, it's a terrible situation. So it's extremely important that you do the investigations to find out to try and define a cause of pain. Clearly document the substance history. This choice of analgesic and route is important. If there was a person like this, I would probably tend to go to a topical formulation and try and avoid OxyContin if I could. We have a number of patients who we think it's best not to prescribe these Actique and Abstral, the rapid-acting fentanyls, because I think that's going to be a significant problem to come because of the really quick uptake. It's the closest thing you get to an IV injection. The use of subcut route rather than IV route, etc., etc., etc. Communication, I think, is very important. You know, discuss the elephant in the room. We'll come in a minute to prior users, but it's very important with the people who have used and don't want to get re-addicted. Acknowledge abusive behaviour and bad behaviour on the ward, set behaviour codes, very strict behaviour codes about how people can act and what will be tolerated and not tolerated, and simply involvement of the GP and community teams, especially home visits, things like 2 nurses, etc. Right? So there are things that you can do. I think we've talked about this. Try and avoid short-acting, rapid onset opioids, clear documentation of any plan. What I tend to do is to write really clearly in the notes that there is to be one prescriber only, and I try and make that the GP, so that coming to clinic can't be coming to get a script. It's all done by the GP, only one person, so the junior staff and the nurses know that they're not to be, that the scripts have to be controlled, so in that way you're not denying people, but you're keeping a very close record on it. Briefly now about specific subgroups. Adolescents are at big risk because they're adolescents, they're risk takers, and it's a particular, this opioid, aberrant opioid associated behaviour, AOB, is more common in adolescents than the elderly. I was just reading one of the papers previously. It's very unusual for the elderly to develop this sort of problem, but much more common in adolescents. And there has been a study done at St Jude's which showed a much higher incidence, about 12% of this aberrant opioid behaviour. What about, so be aware of adolescents and young people, may be more at risk. Prior drug users, this is always difficult. In one study, so this is a surprising number of chronic leukemia, they found quite a few, I suppose predictable people who abuse alcohol, cannabis. A lot of people have tried cannabis at some stage, lower percentage on cocaine. And it is very clear in the literature that people with opioid misuse problems have poorer outcomes and higher mortalities. This question again, however, if people with advanced cancer, is this one pleasure left in life? But it is said, however, that addicts really get pleasure from substance abuse. The first few doses, and I'm not an addiction expert, but the first few doses give people a real high, and from then on it's trying to find that high again. So this is a problem for patients, and patients don't want to be in this sort of situation. They want to be helped through it. Many, and I've had several of these patients, they've been prior users. The last thing they want to do is to go back to being a user again, so they will often be very wary of analgesia and don't want it, and will avoid opioids as much as they can, and that sometimes hampers the treatment of their underlying disease. And often, of course, it's a huge problem for families and carers. Methadone maintenance problem. What do you do with a methadone maintenance problem? If you've got someone on methadone who comes in with pain, who uses the methadone for their cancer pain control? Some. Who uses some other opioid? Yeah. That's what I was always taught. I was told that you should use the methadone is what you're on for your dependence, and keep that very separately from the analgesic you use to keep the pain. Now, I've always thought that was a good scenario, except when I talked to Michael Bolton. Remember Michael Bolton is a very famous palliative care physician in Brisbane and an addiction medicine, and I always thought that he told me that. He said, I never said that, Janet, I just use methadone, so I don't know. I don't think that's right or wrong, but I think that scenario of keeping them separate is quite a sensible thing. People on buprenorphine is more complicated, more complex because of this whole partial agonist thing, and I think most people would try and take people off buprenorphine, either put them on methadone for their dependence or use some opioid altogether. Methadone, people on methadone maintenance are often very wary of this. Once again, like prior users, they are very wary of having further analgesia. They often have tolerance and very rapidly escalating. I can usually tell people have been on opioids before because their dose will go like that and they tolerate it very easily, whereas others who would get toxic from these. I won't go into survivors, just to say that now there's a huge number of cancer survivors out there with pain, and I think Paul has seen a lot of these. There are ASCO guidelines all around this, but this is going to be a problem going into the future. So in summary, really, I just say that every patient is an individual. I think we all need to be aware. We can't pretend it doesn't happen, but there has to be an awareness and some idea of knowing what to do with it. And I'd just like to show this slide. This is top 20 drugs of addiction, and opioids is down here somewhere. Here we are. Look at tobacco, look at alcohol, look at cannabis, so it's important to keep all these things in perspective too. Okay.